Okay, so they've got me wanting to teach you a little something about airway and recovery. Most common thing you're going to see when you have a patient coming out of anesthesia under opiates, under Presidex, or other kind of sedation, most likely it's going to be airway obstruction. Now, the most basic thing to do with airway is a thing we call sniffing position. We always get them in this position before we intubate, and that's what our little Shea headrest is about. You have a couple angles on the airway that you're dealing with. You have, of course, going straight to the back of the neck and then down through the tracheal opening. So to maximize this part of the airway, like you're sniffing a flower, that's why you do that anyway. You reach out to open your airways as much as possible so you can get as much air through your nose to smell that flower. So the easiest way to do that is a jaw thrust. I'm not going to do it because it's very painful. You have I believe that's a hypoglossal nerve that runs across the mandibular angle here. That's a pressure point we used to use in martial arts. So it's very painful, and it would actually stimulate someone that's a little too sedated to want to take a breath. So getting their head in a nice position. We have many morbidly obese patients, as you know. And if you have like extra fat on their back, you have this big fat pad here, and you lay them back, not only will they not be stiff, their head will hang back further and collapse that airway more often. So sometimes it's good to get some blankets or something to put behind their back, more behind their head, and sit them up, get the weight off their chest. All this extra redundant tissue in the airway around the neck, sit them up, get that off of them. Give them a little chance to move a little bit more air. Besides that, of course, you can always go to an oral airway. If you have a lot of our patients have big tongues, redundant tissue inside, especially if they're morbidly obese. A 90 millimeter oral airway is good for 90% of people. You reach in, you pull their tongue as far forward as possible, slide it in, stay off the teeth, and you'll feel it seat. Sometimes the tongue will want to wide up in the oral pharynx. That's not going to work, so you need to reach down, grab the tongue, pull it forward, and put that in. On bigger patients, you go to, of course, 100 millimeters. This one right here is going to take care of the ones the 90% isn't going to cover. And you have smaller ones for children. You can also do nasal airways. Thing with the nasal airways, you really want to lubricate it a lot. And you see this opening on the side, that will grab a turbinate. So turbinate is on the medial side of the nose. So if you go in like this, there's a good chance you're going to grind off a turbinate, and now you're not only going to have an airway that's obstructing, you're going to have a bloody airway that's obstructing. So roll it around, push it in, and then rotate as you're going in if you're using that right nostril. What else they want me to talk about? Angioedema. Angioedema is something that you can have in response to certain medications. Sometimes you can have Ludwig's angioedema, which is due to infection. Basically, you have this big tongue that's blocking your airway. A lot of times that turns into emergency airway in the OR. Oral airway most of the time will help. A nasal airway will help, but most of the time you're going to have to intubate with that. Now, if it is from an anaphylactic reaction, then you can go through all your drugs to treat that. Of course, you got Benadryl, Pepsid. You know, people think it's for acid indigestion, but it's an H2 blocker. Half of the acid in your gut is histamine mediated. So Benadryl knocks out H1, Pepsid gets H2. Of course, you can go to steroids. You can always break out epi if you get in a bind. But this is for your basic anaphylactic type situations. What else we got y'all want me to look at? Aspiration. Aspiration is something you can deal with, especially when you're going under a general anesthetic, because you lose your gag reflex. So you got somebody coming out, they got something in that stomach, it bubbles up, it goes into the lungs. Aspiration pneumonitis is also known as Middleton's syndrome. Middleton's criteria is 25 cc's or more, or once you cross 25 cc's, or a pH of 2.5 or less, it's greater than a 50% chance of causing some serious complications. So a shot glass is 30 cc's. So it really doesn't take much, and if it's particulate, it goes through the roof. So if you've got chunks of something that goes down into the lungs, it's a much more difficult issue you're dealing with. Of course, if you worry about aspiration, you really want to watch their SATs. You're going to want to get a chest X-ray, and they might even have to be reintubated and go to the ICU for the night. All right, let's see if we covered everything there. We'll go to the next. Let's talk about laryngospasm. Okay, that's another thing that's common. Laryngospasm is a reflex. It's It's not really something that a person decides to do or not. The afferent is the superior laryngeal nerve. The efferent, going back, is the recurrent laryngeal nerves that snaps your vocal cords shut. Normally, if you're walking down the street and you suck a fly in and he hits your vocal cords, and you start wheezing, that's the normal reflex. When you're coming through stage 2 anesthesia, it's like really heightened, and when it snaps shut, it doesn't want to break. So it's not that difficult to treat. You just got to recognize it, and you will see stridor. Sometimes you won't hear anything. So definitively, you can push a paralytic, a short-acting like a Nectine, and intubate and get them back going. The first thing you want to do if they're still moving a little air, pop the pressure ventilation. Pop an airway if you need to, put a mask on, breathe with them, give them a little pressure, a little CPAP, and kind of help them break it. Let's see what else we've got here. Let's go to the next one. We talked about head tilt, getting in sniffing positions, suctioning, of course. Sometimes you can have copious amounts of mucus, blood, and nasty stuff you got to pull out of somebody. And we talked about airways that we can pop in. Okay, let's talk about negative pressure, pulmonary edema. Now, this is something you're going to see, especially with young guys that are in shape. What happens normally when you're breathing? When you're taking a breath in, you generate about -4 to 8 centimeters of water per inhalation. As you're exhaling, it'll drop down to -2 to +2 or so. When you have an obstruction, when you've got a glottic obstruction and a young, healthy guy takes a big breath and there's no air moving, he can generate -50, -100 centimeters of water in his lungs. So you have a vacuum in these lungs, and you have all this fluid traveling through all these little capillaries in your alveoli. What it does is it sucks the fluid into the alveoli. So now you've got lungs that are full of water. So you'll see pink, frothy mess coming out of it, and you're going to have a really difficult time with oxygen exchange because what you were using to get oxygen in is now full of water. So I know this is not the greatest deal, but that's what you're going to be dealing with. So give them oxygen, keep a watch on their vitals, probably going to want a chest x-ray on that, and there's always a chance you're going to have to intubate that patient to give them positive pressure ventilation to try to squeeze some of that fluid back into the vascular space. All right, what else they want me to cover? All right, let's talk about other things that can cause you to quit breathing in recovery. Normally, you don't breathe because your body needs oxygen. You're breathing to get rid of CO2. Your normal CO2 is 35 to 45 centimeters of water. As you give opiates, it numbs up the respiratory centers in your brain, and it kind of shifts that to where you need more CO2 to drive ventilation. And that's great because more CO2 will make you breathe faster or will keep you breathing more and more. On a normal patient, once you cross about 80, it turns into CO2 narcosis. The CO2 actually becomes a narcotic itself. It's going to shut the patient down. You reverse the opiates with Narcan, of course. If you need rescue ventilation to help pull their CO2 back down, most time when the Narcan hits and the CO2 is that high, they're going to start panting like a dog and blow it off as quick as possible. Chronic COPDers, it may take 90, 100 or higher to get them into CO2 narcosis because they're used to it. But on your average patient, once you cross about 80, you're going to start seeing some respiratory depression. All right, what else we got here? COPD, asthma, sleep apnea. Of course, sleep apnea patients, if they're already on CPAP, they may need it in recovery. A lot of times we'll tell patients to bring their CPAP with them. What else we got here? Asthma, listen for wheezing. You can always give breathing treatments, steroids, whatever's needed for that. And of course, you always have an anesthesiologist that's pretty close. You can always consult and let him know what's going on and what your concerns are. Off the top of my head, I can't think of anything else. Anybody got any questions we can go with? Come on, it can add to it. Y'all got something? All right. Is that good enough?
That's great.
I'll
Thank you very
sweat
much.
bullets.
Thank you so much.
Great.